Hello, good evening, everyone. Today we will be going to start our Harrison-based symptomatology series. We are here covering CNS symptomology. In last few classes, we have covered LM and UMN weakness, syncope, business vertigo. We have covered raised ICP coma. Last class we have taken about dementia, and here we will take about dementia part two. In last class, I guess we have discussed about memory. We have discussed about how to approach a patient of dementia. We have discussed about reversible causes of dementia. We have also discussed about the various aspects of memory, prefrontal cortex, your temporal lobe, parietal lobe, how all these lobe helps in the functioning. In this lecture, we will move towards one disease by disease. Basically, we will start with Alzheimer disease this time. Okay, everyone? If audio okay, then everyone just give me a thumbs up. Okay. So before we proceed with this class, in last class, especially in previous our class of dementia part one, there we have studied about. Hello Arya, hello Venki, hello Dr. Padmakar Patil. So in last lecture, we have covered about dementia, that the dementia is all about loss of. Hello Harshita Priyanka, hello Redbuck. So in last lecture, we have discovered dementia is loss of cognitive function. Good evening, Dheeraj. Uh, Loss of cognitive function. And I have said that if one out of six, if any of one out of six is positive, we will call that patient as a dementia. So can anybody enlist, because we have studied in last class, what all are the six cognitive functions? Can anybody enlist me the six cognitive functions before we proceed with this class? What are the six cognitive functions? Just anyone can tell me, starting with first. What are the six cognitive functions which we have studied in last class? First is attention. Very good. Attention. Other is your executive function. Then is your social cognition. Then is your memory. Then is your language. And last but not the least is your perceptual motor. Okay, everyone? And we all know that these upper three were controlled by prefrontal cortex, that is your PFC. When it comes to your memory, it is about the mostly temporal lobe. Language is by temporal as well as frontal, and perceptual motor is about parietal lobe. So in last class we have discussed about this now. So here we can see that attention, executive function, social cognition are the integral part of your prefrontal cortex. Memory, especially when we call this memory, especially the hippocampus area. The hippocampus area. So in last class, I have told you about the hippocampus. So can anyone tell me what all memories hippocampus store? It store short-term memory as well as long-term episodic memory. Okay, everyone. In last class, we have discussed about all these things. Na? So hippocampus is about short-term, long-term episodic. Okay. So now we will proceed with this class. So we will start with our topic today, that is Alzheimer. So can anybody tell me what understanding you all have regarding this disease, Alzheimer disease? Anyone? If someone says to you that this patient is suffering from Alzheimer disease, what all things should come in our mind? Okay, very good. One, it is a hello Sharma Puneet, good evening. It is a degenerative disease. Very good. It is a degenerative disease. Okay, good beta. It is a degenerative disease. Other thing, yeah, memory issue, language issues. It is the most common type of dementia. Most common type of dementia, especially in old age people. In old age, greater than 65. Okay. Other thing, it increases with age. It increases with age. No, this frontotemporal dementia, it is also neurodegenerative type, but it is other type. We will discuss about frontotemporal dementia for further slides. Okay, beta. So when compared to Alzheimer, it is a degenerative. Yeah, Dheeraj. If we are saying young onset dementia, then we will say about frontal temporal dementia. A most common type of dementia increases with age. It is also a sporadic type. It is a sporadic type. Okay. Now, can anyone tell me which lobes of brain are affected in your Alzheimer disease? Which lobes of your brain are affected in your Alzheimer disease? Anyone? Can you tell me which lobes of brain are affected in your Alzheimer disease? It is parietal and temporal lobe. This parietal and temporal lobe. Yeah, you can say dominant hemisphere also. So in FTD, name tells itself it is a frontotemporal dementia. So in FTD, which lobes are affected? If in FTD, your frontal and temporal lobe is affected because name is telling itself. But in Alzheimer disease, your main lobe which two are affected are your parietal and temporal. And as the disease progress, it can go to frontal lobe as well as and it can go to global aphasia. It can go to global cerebellum hemisphere. Okay? So initially it will be a parietal lobe, temporal lobe. After after disease onset, after 5 to 6 years, it can also go to frontal lobe. And after fewer, it can spread to all the lobes of brain. So initially, the main two lobes which are affected in your Alzheimer disease is your parietal and temporal lobe. And the most common, or we can say most severe damage, most severe damage in which part? It is in your medial temporal lobe. It is in your medial temporal lobe. And medial temporal lobe, we all know that in medial temporal lobe, which thing lies? It is your hippocampus. And if we want to be more precise, then it can be entorhinal cortex. It can be entorhinal cortex. So in Alzheimer disease, parietal temporal lobe is affected. Okay. Which lobe is most severely affected? It is your temporal lobe. In temporal lobe, it is your medial temporal lobe. In medial temporal lobe, it is your hippocampus part. And near the hippocampus part is your anterorhinal cortex. Anterorhinal cortex, which is affected se more severely. ठीक है? And as lobes are affected, as lobes are affected, it is also known as cortical dementia. It is known as cortical dementia. It is known as cortical dementia. Okay, everyone. Now, what happened in Alzheimer patient? So, can anyone tell me if hippocampus is affected? If hippocampus is affected, which memory will be affected? If hippocampus is affected, which type of memory in these Alzheimer patient will be initially affected? Anyone? We all know in Alzheimer disease, parietotemporal lobe is affected, and in that also most severe damage is at hippocampus. Long term, in long term, which it is your episodic memory. It is your episodic memory. It is your episodic memory, and that also a recent one. That also a recent one. So uh, suppose if I with my father yesterday went to some birthday party, okay, and in birthday party my friends were meeting to my father, okay, and with my friends, a new with my yeah, and with my friend, his girlfriend is also with there. So so me, my father, and my friend and his girlfriend was meeting with my father in his birthday party. Okay. Now today, when my friend was coming to home with his girlfriend, my father doesn't know his girlfriend because the event of birthday in which my father meet his girlfriend, my father is forget because episodic memory. In episodic memory, that episode and all the things related to the episode will be gone, will be washed away. So in Alzheimer disease patient, the recent episodic memory will be gone. So when my friend's girlfriend is coming to my house and my father is like that, who this girl is this? But my father yesterday met to this girl, but now he has forget. So there is a loss of recent episodic memory. Okay, everyone, got this concept? There is a loss of recent episodic memory. Okay. Now in Alzheimer disease later on, you will find that there will be memory loss. Okay, person will be not knowing his disease. He will forget how to wear clothes. He will forget where to urinate. He will urinate in bed itself. You have to put a diaper, adult diaper also, in these kinds of patients because they can't go to washroom. They forget about everything. Even in later stages they forget how to eat also. So when you are feeding them, saliva will come from mouth, but they forget about how to eat. So how you have to see that how severe is this disease. Hello, Madhu Manjari. So I'm repeating. In Alzheimer disease, the disease is so much severe. The disease is so much severe that patient forgets about all the things. Patient forgets about all the things, even his day-to-day activities. Even he can't wear clothes. He can't eat. He has to urinate on bed. You have to put that patient on adult diaper because he will urinate on the bed all the time. And this patient who was earlier so much hygienic now will be converted to an unhygienic patient. He is urinating in his clothes. He is also not changing the clothes. The disease is such much severe that he even can't eat in future. He even can't eat in future. So in USA, in foreign countries, there are special nursing home for caring of these kinds of patients. Okay, and managing this disease is very costly process because you need a constantly nursing care has to give into these kinds of patients. So I'm repeating, Alzheimer is one of the severe disease. Patient generally in these patients, most common when we say what are the most common cause of death, what are the most common cause of death in these patients? It is generally infection, that is pneumonia, because expression can be there. They forget about all the things. You will find this person, he will be roaming in his home and he will forget where is his bathroom. So this patient who is in his home living from 40-50 years, from 40-50 years he is living in his home, but now he's forget where is his bathroom also. And when this patient is going outside, to suppose his patient is going outside and is going outside to buy his grocery, and he has buy his grocery, But now, when he has to come back to home, he will forget the way. In the same colony which the patient is living from 40, 50 years, he even has forget to the way back to his home. So condition is that much severe. So he will forget about everything. Even in the later stages, he will forget how to eat. So when you will feeding him with the spoon, salivation will be coming, but he will be not eating the food. So that much severe condition is there. You have to then put patient on enteral nutrition, rise to feeding. Okay, everyone. So this is the most costly disease and most a burden disease, especially on the relatives part. Because if you are a child and suppose their father, your parent is suffering from Alzheimer's disease, he will forget about you also. He will be not knowing who are you. He will forget about you also. He will not know who are you, and he will also forget that he is suffering from disease. That he is suffering from disease. He is having some kind of problem. He will also forget that. So you have to put that patient on Foley's catheter also because patient will be urinating in his or bed also. So that much severe is this condition. Okay, everyone. So we will proceed further. So in this condition, when it comes to neurotransmitter, when it's come to neurotransmitter, so there is a decrease of acetylcholine mainly. Na and serotonin also decreases, but main decrease in acetylcholine. Why there is main decrease in acetylcholine? Because in this disease, cholinergic neurons, which neurons? Cholinergic neurons of nucleus of basalis, nucleus of basalis of minute are degenerated, are degenerated. That's why we have to put this patient on cholinesterase inhibitor because when you give cholinesterase inhibitor, acetylcholine will increase. So in this patient, cholinergic neurons of nucleus of basalis of minors are degenerated, and there is decrease of acetylcholine. There is decrease of acetylcholine, which is the main pathology of this disease. Main neurotransmitter which is affected in Alzheimer disease. Okay, now we will move forward. So now we are moving to the pathology part. We are moving to pathology part. So can anyone tell me what do you know about the pathology of Alzheimer disease? Because you all have studied about the pathology of Alzheimer disease. Can anyone tell me? So he's like, he is asking that, sir, you have told that episodic memory is lost. Yeah, initially there will be loss of episodic memory, but later on, because of involvement of whole brain, initially there is involvement of parietal temporal lobe, but then after this progress, it will go to frontal lobe. Then all lobes will be involved. So there will be loss of complete long-term memory also. That's why patient will forget everything, even recent, remote, everything he will forget. So can anybody tell me the pathology of Alzheimer disease? Anyone? What do you? Anyone? What understanding you have about the pathology of Alzheimer disease? Pathology. Anyone? So there is involvement of there is involvement of APP gene. Okay, everyone? So there is the involvement of APP gene. APP gene which is present on chromosome 21. and via beta beta secretase it will produce a beta amyloid. It will produce a beta amyloid, and in this condition it is your a beta 42, a beta 42, which is responsible for your Alzheimer disease. Okay, everyone got this concept? It is your a beta 42 in this disease. Now a beta this a beta 42, the a beta amyloid protein, it is deposited around, it is deposited outside neuron. ठीक है, which as your amyloid plaque, which we call as your amyloid plaque. ठीक है, so there is a beta 42 which is deposited outside your neuron, which is known as amyloid plaque. ठीक है, किसी को डाउट यहाँ तक? Anyone having any doubt? Just tell me in comment section. So kindly neuroanatomy के लिए best book, I guess we have studied all from BD Chorsia and Grey's Anatomy, Dr. Vijay. Yes, Sharma Puneet, what doubt you are having? Just tell me in comment section. Just tell me, Batu. Now, now this amyloid plaque contains hyperphosphorylated tau protein. Hyperphosphorylated tau protein. What it contains? It contains hyperphosphorylated tau protein. Now see this diagram. Suppose uh, this is cell body of neuron, and this is your, and this is suppose another neuron. Okay, this is another neuron. Now this A beta, it is deposited outside. It is deposited outside. This is known as your amyloid plaque. This is known as your amyloid plaque. ठीक है? It means it is, this is extra neuronal. क्या है बेटा ये? Extra neuronal. And if this hyperphospholate tau protein, if it is deposited inside, if it is deposited inside the neuron, then it is known as NF, that is your neurofibrillary tangle. ठीक है? And this is intracytoplasmic. या बेटा? ठीक है? So we can say that there is amyloid plaque, there is amyloid plaque, and there is your NF tangles. ठीक है? There is your NF tangles, they contain hyperphosphorylated tau protein. ठीक है? Done everyone? So in this diagram, we can see that it is amyloid plaque. Yeah, tau protein. So this amyloid plaque is outside, and this neurofibrillary tangles are inside. No, no, no. It is hyperphosphorylated, Sharma, not hypo. It is hyperphosphorylated. Okay, everyone? Got this concept? It is hyper, not hypo. Anyone till doubt? Anyone having doubt? Just tell me in comment section. ठीक है? It is hyperphosphorylated. So, हाँ. So there are, if it is present outside, then it is your amyloid plaque that is extraneuronal. And NF tangles are present inside the neuron. They are intracytoplasmic. That is your neurofibrillary tangles. Now, see, this your amyloid plaque. Your amyloid plaque, which is extra neuronal. It is an it is a incidental finding. It is a incidental finding. Means in old age it can be present normally also. In old age it can be present normally also, but if present in excess, then it is Alzheimer. But they can be also present normally also. So they can be present normally also. ठीक है? But your neurofibrillary tangles, that is your NF tangles, they are intraneuronal and they correlate with the severity of disease. They correlate with severity of disease. Means more the number of NF tangle present in that neuron, more severe is the disease. More the NF tangles are present in the neuron, more severe is the disease. Okay, everyone. So see this diagram. Generally, this is the question. Generally, you got especially in your patho exam. This is the NF tangle body. This is your NF tangle. Okay. Now see, neurofibrillary tangle, though not specific for Alzheimer's disease, are a key histopathological feature. Are a key histopathological feature. So you are seeing this NF tangles, and on Silverstone also you can see this. These are your neurofibrillary tangles. Okay, everyone. So what we have studied that there is hyperphosphorylated tau protein. There is hyperphosphorylated tau protein. If it is present in between the neuron, that is extraneuron, that then it is your amyloid plaque, and present inside the neuron, it is NF tangle. And amyloid plaques are can be present normally also. Amyloid plaques can be present normally also, and they are incidental finding in Alzheimer's disease many times. But presence of NF tangles are pathological, and more the NF tangles, more severe is the disease. That it means that the NF tangles presence correlates with the severity of disease. Okay, everyone? Okay. Now we will move forward. We have got pathology partner. Now we'll come to generic part. Now we'll come to genetic factors. Now we will come to genetic factor. So first gene is your chromosome 1. Second is your chromosome 14 defect. ठीक है? In chromosome 1 defect, it is known as your pre-senilin 1. Chromosome 14 is known as pre-senilin 2. Okay, everyone? So pre-senilin, just I will now chromosome 1 correlates with pre-senilin 2 and 14 with pre-senilin 1. Okay, so there is defect in chromosome 1 and chromosome 14, and in chromosome 1 it is known as pre-senilin 2 and chromosome 14 is known as pre-senilin 1. Other genes which are defect, they are your chromosome 19. That is your chromosome 19, and it's correlated with the ApoE gene. It's correlated with the ApoE gene. ठीक है everyone? Till now everyone okay? Chromosome 1 pre-senilin 2, 14 pre-senilin 1, and chromosome 19 defect is your ApoE gene. हाँ, it is your ApoE 4. This is your ApoE 4, and it is a most important single most important biological marker for Alzheimer disease. ठीक है? Next is your chromosome 21. So can you tell me chromosome 21 is for? It is your Down syndrome. It is your Down syndrome. It is your Down syndrome, and it generally present at the age of 35 years, and it is known as pre-senile dementia. So just we will revise all the genes starting with chromosome 1, that is your pre-senilin 2. Then is your chromosome 14, it is pre-senilin 1. Then comes chromosome 19, it correlates with ApoE gene, ApoE4 defect is there. Then comes it is single most important biological marker for Alzheimer's disease. Last is your chromosome 21, which correlates with the Down syndrome. And it presents around about 35 years. Generally, we know Alzheimer present about at 65 years, but this present around 35 years. That's why it is known as pre-senile dementia also. So everyone, till now, okay, just give me thumbs up. Everyone, any problem in this genetic factors or pathology part, just tell me in comment section. Then we move on to clinical feature part. Everyone okay with this pathology and genetic factor? Shall we move forward? Okay. Now, before moving forward, now we will first see some risk factors. Some risk factors. Some risk factors. That is your age greater than 65 years. Then comes your diabetes. Then comes your stroke. Then comes a positive family history. A positive family history. And most important, that it is more common in female as compared to males. It is more common in females as compared to males. And then is your history of head trauma. History of head trauma. Okay, everyone. So these were your risk factors. Now we will start with the disease part. See, when it comes to pathology, when it's come to pathology, so we have studied about pathogenesis, that is the NF tangles and your amyloid plaque. We all know the which part is most affected. It just tell me in comment section which part is most severely affected in your Alzheimer disease. Which part of brain is most severely affected in your Alzheimer disease? Just tell me in comment section. Which part of brain is most severely affected in your Alzheimer disease? Just tell me which part of your brain is most severely affected in Alzheimer disease. Anyone? Middle temporal lobe. Good. So there is a diffuse atrophy. There is diffuse atrophy of brain. क्या होती है ब्रेन की diffuse atrophy? Second, most important and most earliest is your hippocampal atrophy. Hippocampal atrophy. Most earliest finding is your hippocampal atrophy. ठीक है? Then everyone, most important pathology are diffuse atrophy of brain. Then comes your hippocampal atrophy. And last but not the least are your amyloid plaque and NF tangle. ठीक है? Then so see this diagram. ठीक है? We are seeing a brain cross section here. क्या देख रहे हैं हम? ब्रेन का क्रॉस सेक्शन. So wait a minute. Before we proceed, we will first see a basic concept. Now see this is your brain. This is your left hemisphere and this is your right hemisphere. Brain is made. Your brain is made up of your gyrus and sulcus. You are seeing this is the gyrus and this is your sulci. The deep groove in that deep groove is sulci. There in your cerebral cortex is made up of your gyrus and sulci. So between two gyrus, suppose these hands are my two gyrus. Between two gyrus, this deep groove, this is gyrus, this is gyrus, and this is gyrus. And between these gyrus, this deep groove is your sulci. So you are seeing this diagram. These are your gyrus, and between two gyrus is your sulcus. Between two gyrus is your sulcus. Now tell me, if I am saying that there is loss, or you can say if there is diffuse cerebral atrophy, there is diffuse cerebral atrophy. What does it mean? It means that there is loss of or thinning of thinning of gyrus. ठीक है? ये बात सबको समझ में आई? Everyone got this? If I am saying that this patient of Alzheimer patient has a diffuse cerebral atrophy, it means cerebral has shrunken. And which part will be shrunken? Your gyrus part. So there is loss or thinning of gyrus. Now see, if these were my gyrus and this depression was sulci, but now my gyrus are thinning of gyrus is there due to cerebral atrophy. Now suppose if gyrus will thin or shrunken, the space between them, that is sulci, it will increase and it will get widened up. Are you seeing this? Suppose these are your gyrus, okay, and this in between gyrus is your sulci. Now due to cerebral atrophy, your brain is getting shrunken. Your brain is getting shrunken. So gyri will get shrunk. If gyri will get shrunk, this space will increase, which was present between them. That was your sulci. So loss or thinning of gyrus plus there will be widening of sulci. There will be widening of sulci, or you can say that there will be prominence. There will be prominence, widening of sulci. Yeah. So if you are doing this patient CT scan or MRI, so what you will get? You will get widening of sulci and you will get loss of gyrus. Okay, everyone. If suppose this is a normal patient, so if these are your gyrus, okay, ठीक है, and this space is your sulci. Okay. Now, if this is your Alzheimer patient, this is your this is your Alzheimer patient, where there is loss of, or you can say thinning of gyri. Now, what will happen? See, if they will shrunk, it will be like this. So you can see the sulci has widened up. The sulci has widened up. Yeah, I will tell you about Sharma Puneet about this concept also. ठीक है, तो हमें ये बात समझ में आ गई कि लॉस ऑफ गायरस होगा, साथ में बाइंडिंग ऑफ सल्काई होगा. नाउ, सो दिस इज योर नॉर्मल ब्रेन, sulci and gyrus. Now gyrus has thinned, so sulci has widened up. Okay, sir. And you can see that this part which is affected in this diagram, you can see this memory part which is affected. This is your medial temporal lobe. This is your medial temporal lobe. That is your hippocampus. That is your hippocampus. Okay. Now see another diagram. This is your brain. This is cerebral cortex. There is atrophy in Alzheimer disease, and you can see the atrophy of hippocampus. And when hippocampus get atrophied, there is enlargement of ventricle, which is present near it. So see this diagram. Mm. See, this is inferior temporal horn of lateral ventricle. This is inferior temporal horn of lateral ventricle. This gap, ठीक है? ये this gap, this, ठीक है? So normally, can you see? No, this is so small. Generally, we can't see, but there is a concept in brain. There is a concept in brain that when when your brain gets shrunk, when there is cerebral atrophy, in compensation of this, the ventricle size get increased. In compensation of it, the ventricle size get increased. So here in Alzheimer's disease patient, when there is extreme shrinkage of hippocampus, when there is extreme shrinkage of hippocampus, you can see enlarged ventricle, and this phenomena is called your X X X vacuum dilatation of ventricle. It is known as X vacuum dilatation of ventricle, or we can say that it is a pseudo dilation of ventricle. Normally, ventricle size is normal, but due to atrophy of brain, when brain gets shrunken, your ventricle appears big. Your ventricle appears big. So this is X vacuum dilation of ventricle, which is due to thinning of, or we can say due to diffuse cerebral atrophy. Due to diffuse cerebral atrophy. Okay. So normally you are not able to see the inferior temporal horn of lateral ventricle, but due to extreme shrinkage of hippocampus, you are seeing this ventricle enlarged. So in your life, whenever you will encounter a CT MRI in which you are thinking that there is pseudodilation of ventricle, just see the cerebral hemisphere. If there is cerebral atrophy, if there is widening of sulci and loss of gyri is there, then it is a ex vacuo dilatation of ventricle. It is ex vacuo dilatation of ventricle, also known as your pseudodilatation of ventricle. Okay, everyone. If everyone has got this concept, just give me thumbs up. Then we move forward. There is, you can see now, first is your diffuse atrophy of the hippocampus and it leads to ventricular enlargement. सबको समझ में आ गया ventricular enlargement? Just give me thumbs up. Sharma, Puneet, Dheeraj. Okay, everyone. See, we will see another diagram also. See, this is your cerebral cortex. Okay, sir. This is the your normal brain. This is a diagram of a normal brain. Cerebral cortex is there. Okay, ventricles are there. See this ventricle. Can you see this ventricle normally? No, it is very thin. Normally, it is very thin. You can't see. But at this hippocampus, if this hippocampus, if this hippocampus atrophy is there, if this hippocampus atrophy is there, then you will see this ventricle very much clearly. So see this diagram. Due in early Alzheimer disease, you are seeing shrinkage of cerebral cortex. Yeah, sir, we are seeing the shrinkage of cerebral cortex and shrinkage of this hippocampus. This hippocampus has shrunken, and due to shrinkage of hippocampus, what has done? There is moderately enlarged ventricle. There is moderately enlarged ventricles. Okay, everyone. This ventricle has enlarged. See, now when we come to severe Alzheimer disease, this was your early Alzheimer disease. When you come to severe Alzheimer disease, see how much ventricles have enlarged. How much ventricles have enlarged? How much ventricles have enlarged? There is shrinkage of your hippocampus and shrinkage of your anterorhinal cortex. Because we have known now in medial temporal lobe, that is your hippocampus and anterorhinal cortex, which are most severely affected. So there is shrinkage, and due to their shrinkage, there is dilatation of ventricle. There is dilatation of ventricle. See, extreme shrinkage of cerebral cortex. Yes, sir. Severely enlarged ventricle and extreme shrinkage of hippocampus. सबको समझ में आ गई? Everyone got this anatomical diagrams? Is anyone having any doubt? Just tell me in comment section. Are you comfortable with this anatomical diagrams? There is extreme shrinkage of cerebral cortex and there is severely enlarged ventricles. So when you are doing dissection, especially Alzheimer patient, you will get these findings. Now we will correlate this anatomical finding when we are seeing the CT and MRI. We will correlate this anatomical finding with CT and MRI of the Alzheimer disease patient. So see, this is a typically 25-year-old patient, his hippocampus. This is a typically 75-year-old patient. Okay, as patient is normal, nothing to worry. Patient is normal, nothing to worry. 75-year-old. But if this patient has got mild cognitive impairment due to Alzheimer's disease, see, atrophy has begun. Atrophy has begun. And we all know, what do you understand by the term mild cognitive impairment? I have told in earlier class that cognitive function loss is there, but patient can do day-to-day activities. Patient can do day-to-day activities. But in dementia, that is the major cognitive impairment. You can't do your day-to-day activities. So here you are seeing the cerebral atrophy. So much cerebral atrophy is there. So much cerebral atrophy. And your hippocampus, so much small. So much small and shrunken. See another diagram. See this. This is your normal brain. This is your normal brain. And this is your brain of the Alzheimer disease patient. See, are you seeing the cell? See in this diagram. Just compare. These are your gyrus and these are your sulci. See this sulci, how prominent it is. See this sulci. See this sulci, how prominent it is. And see this gyrus, how thin they are. How thin they are. And you can see, na, there is diffuse, diffuse cerebral, there is diffuse cerebral atrophy. There is diffuse cerebral atrophy. Everyone, okay? Shall we move forward? सबको यहाँ तक समझ में आ गया? Just give me a thumbs up. Just give me a thumbs up. And now tell me what you will see in whenever you are seeing the CT scan or MRI of Alzheimer patient. Whenever you are seeing the CT scan or MRI of the Alzheimer patient, what finding you will see? Just tell me in comment section. Just tell me in comment section what finding you will see in the CT scan or MRI of the Alzheimer patient. White cell count. Okay, good. See this diagram. Yes, you just see this diagram. This is the MRI and this is a corneal section plane. This is a corneal section plane. This is MRI and a corneal section plane. See normal patient. See normal patient. You can see hippocampus. Yeah. See the ventricle. Is this ventricle not? No, it is not enlarged. But see this diagram. There is diffuse atrophy of temporal lobe. There is diffuse atrophy of temporal lobe. See the ventricle has a enlarged compared to previous diagram. Compared to previous diagram, your ventricle has enlarged. Okay, sir. See this sulci, how old is this sulci? And see this sulci, how widened this sulci is, and see the gyres, how are this and how thin they become in this diagram. So you are seeing MRI or CT scan. What you will notice? Sulci widening. You will notice in especially atrophy of temporal and parietal lobe and the ventricle, the inferior horn lateral ventricle, inferior horn of lateral ventricle near hippocampus, it will get widened up due to X vacuodilatation of ventricle. Whenever there is shrinkage of cerebral hemisphere, ventricle take that space. Whenever there is atrophy of, whenever there is atrophy of cerebral hemisphere, ventricles, ventricles take that space. ठीक है? Done. See normal atrophy. Okay, normal hippocampus. See this hippocampus and this hippocampus. Now see this atrophy of temporal lobe and widening and widening. ठीक है? See, uh, someone has bring to a CT scan. Someone has bring to a CT scan of a patient of Alzheimer's disease. What we will see? See, there is enlargement of cerebral sulci. There is enlargement of cerebral sulci, loss of gyral volume, and dilatation of ventricle. Dilatation of ventricle is there. ठीक है? सबको समझ में आ गया? Everyone has cleared till now? Just tell me in comment section. Everyone, are you okay with this concept or shall you move forward? धीरज शेरनी शिरमापरी सबको समझ में आ गया? What all are the anatomical findings in Alzheimer disease brain cut section? And you will correlate this anatomical finding, diffuse atrophy, enlargement of ventricle, with the findings you will find that in your CT scan and MRI. Just tell me, Dheeraj, Sirni, shall we move forward? Okay. Now, just tell me. Now, suppose you are seeing a CT scan or MRI. You are seeing a CT scan or MRI for patient. Okay. And on on seeing the you are seeing a CT scan or MRI for patient. On seeing a CT scan or MRI, there is dilatation of ventricle. See, dilatation of ventricle present in this diagram also. But we all know that there is a condition. there is a condition known as normal pressure hydrocephalus. That is your NPH. That is your normal pressure hydrocephalus. In that also dilatation of ventricle is there. In that also dilatation of ventricle is there. So when you will see that patient CT MRI, you will ask me, sir, ये dilatation of ventricle तो Alzheimer disease में भी है, and dilatation of ventricle NPH में भी है. Then how we will be able to differentiate? Is this a dilatation of Alzheimer disease or is this a dilatation of normal pressure hydrocephalus? Because you have said that dilatation of ventricle will be in Alzheimer disease also. Now see, in NPH, you are seeing first there dilatation of ventricle. There is dilatation of ventricle in NPH also. But see first thing. First, there is a gross dilatation. There is a gross dilatation compared to Alzheimer's disease. There is dilatation, but not gross. Second, the most important crux finding that you find in your Alzheimer's disease is that loss of gyri and widening of sulci. Can you see this in NPH? No. Your gyri and sulci will be normal here. Will be normal here. ठीक है? But in that, gyri and sulci will be loss of gyri and widening of sulci will be there, and there will be ex vasodilation of ventricle. Everyone, yeah, Shirni, we will discuss about this in further slides about NPH. सबको ये बात समझ में आ गई? How to differentiate between Alzheimer and NPH on CT or MRI? This is the patient of Alzheimer disease. This is the patient of, there is dilatation of ventricle. There is dilatation of ventricle. So either it can be Alzheimer or it can be your NPH. But in NPH, there will be a gross dilatation. In Alzheimer disease, there will be loss of gyri and widening of sulci. And it results in ex vacuo dilatation of ventricle. But in NPH, your gyri and sulci will be normal. सबको समझ में आ गया everyone? Shall we move forward? Anyone having any doubt? CT scan, MRI, normal findings of anatomical section of Alzheimer's disease. We have compared the Alzheimer's disease with NPH also, especially when it compared to CT or MRI findings. That is the enlargement of ventricles. How to know it is Alzheimer's disease or how to know it is NPH? Anyone, any doubt till now? Just tell me, or then or shall we move forward? Everyone okay till now? Everyone is okay till now? Just give me a thumbs up. ठीक है. Now, see, before we will go to the clinical features. Before we go to the clinical features of Alzheimer disease, we will first take in the look into about something in parietal. We will go in clinical feature, but before we go, we will see something important about parietal lobe. Now, see, this is your parietal cortex. This is your frontal lobe. This is your parietal lobe. This is your temporal lobe, and this is your occipital lobe. ठीक है everyone? This is your frontal, parietal, temporal, and occipital. Okay, done, sir. Now, in parietal lobe, see this diagram. In parietal lobe, na, two important structures are present. In parietal lobe, two important structures are present. This is your supramarginal gyrus, and this is your angular gyrus. This is your supramarginal gyrus and your angular gyrus. ठीक है? Now we will study what are the functions of this supramarginal angular gyrus, because these two are very, because these two structures are damaged in Alzheimer disease. These two structures are damaged in Alzheimer disease. So first we will look into about कि parietal lobe में जो supramarginal gyrus है और angular gyrus है, इनका क्या function है. So can anyone tell me in comment section what is the function of supramarginal gyrus in parietal lobe? What is the function of supramarginal gyrus in parietal lobe? Can anyone tell me in comment section? So this slide is about, we will study parietal lobe, and in parietal lobe, two important things about parietal lobe, that is your supramarginal gyrus. So can anyone tell me what do you understand by the term supramarginal gyrus? So its function is, paraxis. Its function is paraxis. क्या function है इसका? Paraxis. So if it is affected, it will lead into, if there is lesion in supramarginal gyrus, it will lead into apraxia. It will lead into apraxia. So now anyone can tell me what do you mean by the term apraxia? What do you mean by the term apraxia? Can anyone tell me? What do you understand by term apraxia? Can anyone tell me in comment section what do you understand by the term apraxia? Anyone? So see, apraxia means it is inability, it is inability to carry out a voluntary motor act, a voluntary motor act in the Yeah, Tanisha, whole video present in this channel. Good evening, Rishali. But why are you so much late? So, inability to carry out a voluntary motor act in the presence of normal motor and sensory system and your cerebellum also. So, what do you understand by this definition of ataxia? It is inability to carry out a voluntary motor act in the presence of normal motor and sensory system. Now, suppose I am fully okay. I am fully okay. ठीक है? My UMN pathway, LMN pathway, everything is open. No weakness in my body. But when I am opening my shirt, when I am unbuttoning my shirt, I am finding it difficulty in this task. I am taking this pencil. This is okay. Everything is okay. But when I am undressing myself, whenever I am unbuttoning my shirt, only this part is affected. So when a patient comes to you, he tells, "Sir, I am not able to do this specific task. I am not able to. I am having difficulty in unbuttoning and buttoning a shirt, or if I am having difficulty in making chapati, but I can do all the tasks." So he can do all the tasks. It means his all things are normal. His weak, there is no weakness. His LMN, UMN, mountain sensory, all system are okay. But doing a particular task, there is a problem. So this is known as the apraxia, and this, if I am problem unbuttoning, it is a dressing type of apraxia. ठीक है. Thank you, Harnik. Now, has everyone got the definition of apraxia? It means सब कुछ ओके है, सब कुछ ओके है भाई, हाथ पैर वीकनेस सब सही चल रहा है, कोई दिक्कत नहीं है, बट एक पर्टिकुलर टास्क करने में मैं पेंसिल लिफ्ट कर पा रहा हूँ, हाँ कर पा रहा हूँ, सब कुछ काम कर पा रहा हूँ, गाड़ी चला पा रहा हूँ, चला पा रहा हूँ, बाइक चला पा रहा हूँ, चला पा रहा हूँ, बट जब मैं अपने आप को अनबटनिंग बटनिंग कर रहा हूँ, व्हेन आई एम ओपनिंग माई शर्ट बटन, I am finding it difficulty. So this is apraxia. In every task, there is no problem, but a particular specific task, you find it problem or you find it weakness there. You can't able to do that particular task. This is your apraxia. Anyone having any doubt in apraxia, just tell me. I will repeat. Anyone having any doubt in the concept of apraxia, just tell me. So there is supramarginal gyrus. The function is of paraxia. If there is a lesion in supramarginal gyrus, it will lead into apraxia. Apraxia, what is this? It is the inability to carry out a voluntary motor act in the presence of normal sensory system. ठीक है? So everything is okay, everything is fine, but still, suppose if I am not able to lift this pencil, I am not able to lift this pencil, but I can do every task. I can roam here and there, I can play cricket, I can do everything. There is for me specific task. This is your apraxia. This is your apraxia. Yeah, Shirley, you can say the skill moments are particularly affected, but a particular task is affected. A particular task is affected, and all your motor competency components are normal. All your motor competency components are your normal here. After the supramarginal gyrus, the other important structure which we have to study in parietal lobe is your angular gyrus. Is your angular gyrus. अब angular gyrus का क्या function है? Its function is gnosis. Gnosis. And if there is a lesion, what do you understand by term gnosis? It is the ability. It is the ability to recognize any object by touch or vision or by sound. And if there is a lesion, it is known as agnosia. It is known as agnosia. ठीक है? Everyone got this one? What is agnosia? Now suppose if my angular gyrus is affected, ठीक है? So it is the ability to recognize any object. Okay. Now suppose my touch part, my touch part is affected. So suppose I have closed my eyes. Normally, if I am closing my eyes, I can recognize this by touching. This is the pencil. But suppose if the in agnosia, my touch part is affected. So when I have closed my eyes, can I tell this is pencil? No, I can't tell this is pencil. This is agnosia. If suppose I am suffering from visual agnosia, I am suffering from visual agnosia, and I'm seeing this pencil, but I will be not able to tell this is pencil. I will be able to not tell this is pencil. But while touching, I will be able to tell. So these are agnosia. It is your ability to recognize any object, and it is done by three sensations: your touch, vision, or sound. If any of them is impaired, suppose your vision part is impaired, then is visual agnosia. If touch part is impaired, then is your tactile agnosia. Okay, everyone. So in parietal lobe, there are two important structures which we have studied. That is the supramarginal gyrus. If there is lesion, it leads to apraxia, and there is your angular gyrus. If lesion is this, then it leads to agnosia. It leads to agnosia. Okay, everyone. Now we'll moving further. Now, now, now we will move to yeah. Now we'll move to the clinical features, or we can say disease progression and clinical features. So we will know about how the disease progress, because there is a characteristic pattern in Alzheimer disease of progression of disease. So tell me first, which part of brain is first affected in Alzheimer disease? Which part of brain is first affected in your Alzheimer disease? Just tell me this. Which part of your brain is first affected in your Alzheimer disease? Just tell me. Which part of your brain is first affected in your Alzheimer disease? Just tell me. It is your medial temporal lobe. That is your hippocampus. So disease will start from hippocampus. Disease will start from hippocampus. After medial temporal lobe, this disease, it goes to lateral temporal lobe. It goes to lateral temporal lobe. And in lateral temporal lobe is your semantic memory. After that, it goes to your parietal lobe. It goes to parietal lobe. ठीक है? Done. And after parietal lobe, it goes to frontal lobe. It goes to frontal lobe. So if I draw a diagram, see, this is the diagram. This is the frontal. This is parietal. This is temporal. This is occipital. And if I want to know how does this project, it goes like this: first temporal, then parietal, then frontal. First temporal, then parietal, then frontal. And we have got to know that mostly it first affects the parietal temporal lobe. And in later part of the disease, it involves frontal lobe, or it can then involve the whole cerebral hemisphere. So how is this going? It is going like this: temporal, parietal, frontal. So in anti-clockwise fashion, in anti-clockwise fashion from temporal lobe, and more precise to be middle temporal lobe, and more precise to be hippocampus. Most precise is to do hippocampus. आगे सबको समझ में? पहले कौन सी होती है? पहले कौन सी? टीपीएफ. क्या निमोनिक है हमारा डिजीज प्रोग्रेशन का? इट इज, दिस इज हाउ द डिजीज प्रोग्रेस. This is how the disease progress. And what is the mnemonic? TPF. TPF. Temporal, parietal, frontal. डायग्राम ड्रॉ करेंगे सीधा एंटी क्लॉकवाइज. पीपीएफ सिर्फ ऑक्सीपिटल को स्प्रेड. वी आर स्टार्टिंग फ्रॉम टेम्पोरल, ऑक्सीपिटल को स्प्रेड करना है. So if we are starting from temporal and we have to spare occipital and we have to go to frontal, so we in between which lobe will you find? Parietal. So it is TPF. It is TPF. We all know occipital carry visual, and in a exam your occipital lobe is not involved generally. ठीक है? So we have to go for temporal, and temporal in last is your frontal lobe. So in between temporal or frontal is your parietal lobe. So we will go from anti-clockwise fashion. So if we start from temporal lobe, we will go in anti-clockwise fashion till frontal lobe, and we will find in between your parietal lobe. We will find in between your parietal lobe. So it is TPF. Everyone got this concept? Tanisha, Harniklal, Sydney, Rishali, are you comfortable how the disease progress in Alzheimer disease? Just tell me in comment section. Then we'll move forward. How the disease progress in your Alzheimer disease patient? Is everyone okay? Just tell me in comment section. Then we move forward. Okay. So see now, now, now we will come into the clinical features part. Okay. We have studied the disease progression. Now we'll come to clinical feature. Okay, sir. So first, which lobe is affected? Your medial temporal lobe. Your medial temporal lobe, and that is your hippocampus. ठीक है? अब बताओ, if middle temporal lobe is damaged, so which memory will be gone? Your episodic, your episodic memory impairment. Done, sir. After middle temporal lobe is which lobe is your involved? It is your parietal lobe. It is your parietal lobe. And in parietal lobe, first is your involvement of angular gyrus. Is your angular gyrus, and it leads to anomic aphasia. It leads to anomic aphasia. It leads to anomic aphasia. Okay. After that, it affects your it affects your supramarginal gyrus, and it leads to apraxia. Anomic aphasia is when it is difficulty naming any object. When there is difficulty in naming any object. Suppose if you will ask me what is this, so I will tell you this helps in writing. I write with this object. It is very good, but I can't say this is pen. I will tell all things related to this thing, but I can't name this is pen. So only naming is affected in anomic aphasia. In anomic aphasia, only naming is affected. That is by your angular gyrus. And how aphasia is there, we will study in our aphasia lecture. So in parietal lobe, angular gyrus is affected. That is anomic aphasia, supramarginal apraxia. And if non-dominant lobe is there, if non-dominant lobe is affected, then it leads to visuo visuospatial disorientation. It leads to visuospatial disorientation. And after that, which lobe will be coming? After that, your frontal lobe. And in frontal lobe, your prefrontal cortex. And you all know in prefrontal cortex, what all things will be have affected? Your executive function. Executive function gone. Your attention is affected. Your attention is affected. Okay, everyone. So, in nutshell, if we come to disease progression, it is your memory, your temporal lobe, then is your anomic aphasia, then comes the language part. Done, sir. After language, your visuospatial function is affected, and after that, your executive function is affected. This is how the disease progress. The disease progress. And when your prefrontal cortex is affected, then patient can't keep the track of finances, can't keep the track of finances. ठीक है? Generally, you see na the old patient of Alzheimer patient, they all are normal patient of old patient. They all know how to spend money, how to calculate what money to give. So they are very good at finance. So, but when Alzheimer disease is there, when prefrontal cortex is affected, they can't keep the track of finances of there. So they will giving 500 rupees instead of 10 rupees. So that's the problem happening when prefrontal cortex is involved in this patient. So we will have start. First is your memory gone, then your language, then your visual spatial dysfunction, then executive function. So see here, middle temporal episodic memory impairment is there. Then parietal lobe, episodic memory. I have told you, recent memory will be gone. Parietal lobe, angular gyrus will be affected. That is your anomic aphasia. Then comes your apraxia. Then comes your non-dominant lobe. That is your visual spatial disorientation. And then comes your frontal lobe. That is your executive function is gone. Your attention is affected. So just see this diagram. How this disease is going? It is. If this is my temporal lobe. If this is my temporal lobe, it starts from here. It goes from here, angular gyrus is affected, then supramarginal gyrus is affected, then it affects the prefrontal cortex. And sometimes when this disease is going, sometimes it involves the Wernicke's area also. Sometimes it involves the Wernicke area also. Then Wernicke aphasia can also be there. Then sometimes Alzheimer disease also involve your Wernicke's area, and then it will lead to Wernicke's aphasia. And we will be studying about aphasia in our next lecture. Okay. So this is how the disease progress. First, memory impairment is there, then your language is gone, then your visuospatial disorientation is there, and then your executive function is gone. Yeah, good. So, can anyone tell me about the visuospatial disorientation? About the we have seen in this pathology, there is visuospatial disorientation is there. So, what do you understand by term visuospatial disorientation? So, it means visuospatial disorientation means visuospatial abilities consists of the ability to understand what we see, around us, and interpret the spatial relationship. In other words, it includes both the images we see as well as the perception of the size and the location of the surrounding. So, what does it mean? To draw, so to draw 3D objects, to draw 3D objects for for navigation purpose. It helps in your driving. Okay, orientation of your surroundings, orientation of surroundings, orientation of surroundings. ठीक है? So these all things are affected in your when your visual spatial is gone. Visual spatial disorientation is there. See this diagram. When it's come to making of 3D figures, when it comes to making of 3D figures, can you draw these 3D figures? No. See, this is a normal patient, and this is a Alzheimer disease patient. See, he's not able to draw cylinder. He's not able to draw the table. And when we tell him to draw a watch, see how he has drawn the watch. So when I will tell Alzheimer patient to draw a watch, he will draw a watch like this. Suppose this is a normal watch, so he will draw watch like this. Suppose he will number all the numbers on the one side only. 1, 2, 3, 4, 5, 6, 7, 9, 10, 11, 12. All the number on one side only. All the number on one side only. And there are two handles in a watch, and he will draw only one handle because there is a loss of visual spatial disorientation is there. And when we will tell him to draw a 3D figure like this, if I am telling him to draw a cube, he will draw something like this. He will not able to do the visual spatial disorientation. And due to visual spatial problem, there will be navigation problem. So suppose this 65-year-old patient, such much navigation problem is there that he can't locate his or her toilet also. So he will go to kitchen and he will say this is toilet. Such navigation problem is there. So when this patient are driving, they can drive properly, they can put the gear properly, but there is a navigation problem. They don't know the route. They don't know how to get back to home because there is a navigation problem. Because there is a visuospatial disorientation. They forget the rooms in their home also. They go to kitchen and they call this as a bathroom. And they go to bathroom, they call this as a kitchen. So there is a navigation problem also. There is a visuospatial disorientation. When you tell them to draw 3D figure, they are not able to draw 3D figures. When I tell them to draw a clock, when I tell them to do a clock test, see how he has all the number 1 to 12 on the one side and had drawn only one handle. When I told him to draw a cube, see how he has draw the cube. So he will be not be able to draw the 3D figures. Okay, everyone. Everyone has got till this now. Just tell me in comment section. Rishali, we, I will be telling you this difference in my next lecture, na beta, because it is a huge topic, na it will get late. Okay, beta Rishali. So just tell me, Rishali, Dhirij, Puneet, Have you understand about visuospatial disorientation? Have you understood? Now, Dheeraj, this is hemi-neglect. You are good. But this is hemi-neglect. This will come under other heading. Okay, Dheeraj, we will study about this hemi-neglect in our next class. This is because that class is related to aphasia and all parietal lobe function of non-dominant, that is your visuospatial hemi-neglect. So hemi-neglect is something different from visuospatial. So if I am a patient of Alzheimer disease, what will be I am suffering? I will suffer from episodic memory. I will be not knowing if suppose there is a last party. So what new people I met in that party, I will forget first thing. Other is anomic aphasia will be there. Language issue will be there. I will be not be able. I will say this thing is used for writing, but I will be not able to name that it is the pen. I will not be able to tell this is pen. So language issues there. And initially anomic aphasia there, and later on warning aphasia is also there. There is apraxia. I can't button my shirt, but my motor component will be normal. Then there's a visuospatial disorientation. There will be a problem in navigation. There will be a problem in navigation. There will be problem in navigation. I will be not be able to locate the things in my room also. See how the problem is even this Alzheimer patient. They are not able to in which house they have lived for 25 to 30 years. But now they don't know where is the toilet because their disorientation navigation map also. Then comes to frontal lobe. He can't even keep the track of finances. He can't even keep the track of their finances. Executive function are gone. Attention affected. So first memory, then language, then visuospatial function are gone, then executive function. This how the disease progress in Alzheimer disease patient. See, first is mild cognitive impairment in the Alzheimer disease patient. Okay, only hippocampus is involved and there is memory loss. Okay, done. And initially, if it is MCI, then daily activities will be normal. Then it is mild, it suppresses to later temporal lobes and parietal lobe. And if go to later temporal, then semantic memory is also gone. Then semantic memory is also gone. Then in suppressed to frontal lobe. And then you can see there is a widespread brain atrophy in the severe disease. Okay, everyone. Shall we move forward now? Shall we move forward? And there is one more important. No, beta, I am single. Now, there is another clinical feature also in this patient, that is your anosognosia. That is anosognosia. So, what do you understand by anosognosia? That is lack of self awareness. That is the lack of self awareness. Such lack of self awareness is there that patient urinating in his pant and he is still okay. And he is still okay. Okay. So anosognosia is also there. Now we will come into the investigation part. Now we will come into the investigation part. So in investigation, yeah, Calvin in later stage of disease, this also. So when it comes to investigation, the basic screening test, the basic screening test, the basic screening test is your MMSC. Is your MMSSC. So how to do this MMSC? In MMSC, total, this is a MMSC chart. This is a MMSC chart. Okay? Now, in MMSC, there are total 30 points. There are total 30 points is there. See, there are total 30 points in which you also have to try to draw a patient 3D figure like pentagon. You have to ask which year is this, season, date, day and month, where are you now, state, country. You tell them to count backwards and then subtract -7 from each digit. Then you ask them to repeat some phrases. So you have to do all these things. Ask about memory, visual spatial ordinary, all these things are there. So if MMSC is total score is around 30, but if it is between 21 to 24, then it is a mild disease. If it is around 10 to 20, then it is moderate. And if it is less than 10, then it is severe. Then this is severe. Okay, Rishali, whenever this will happen, I will share their pics with you. Okay, beta? So total 30 is there and mild is 21 and moderate is severe. So MMSC, MMSC is only a screening test. So that patient enters. It is a screening test, not a confirmatory test. It is a screening test only. So total score is 30. This is a chart. You can also Google it, this chart. In this all memory, visual pattern, how to tell the patient how to draw, what to numbers to repeat, it is given. Yeah. Shirley, it is used for dementia patient only. MMSC, MMSC is used for your dementia patient. For your dementia patient. MMSC is used for dementia patient. Okay. It is a screening test. Now, after this, we will move to investigation of choice. And what is the investigation choice? Is your MRI, and that is your functional. That is your functional MRI. That is your functional MRI. ठीक है? Greater than your MRI. And what all you will see in MRI, I have told you. There will in functional MRI, you can see the volume of hippocampus. In functional MRI, you can see the volume of hippocampus because hippocampus will be get shrunken, so you can see the volume. They decrease in hippocampus volume. That's why functional MRI is more important as compared to MRI. You can see pseudo dilatation of ventricle. You can see pseudo dilatation of ventricles. You can see the pseudo dilatation of ventricles and loss of gyri and prominence of sulci. All these things you can see in MRI. Then everyone okay till this now? Investigation choice is MRI. Now we can also do a PET scan. See, these all are the findings of MRI. I have told you. Other thing you can do is the PET scan. In PET scan, you will be finding that there will be hypometabolism. You will be finding hypometabolism in temporoparietal cortex. क्या मिलेगा आपको? Hypometabolism in temporoparietal cortex. See this diagram. This is a normal patient. This is a normal patient. And in Alzheimer disease patient, see in this frontal lobe. This is sorry. You can see the see in this temporal lobe, and here see this temporoparietal lobe. There is hypometabolism. There is hypometabolism. So first screen test is your MMSC. Then you can do your MRI to confirm the diagnosis. Then you can do a PET scan also. In PET scan, because they, in Alzheimer disease, the temporal parietal lobe is affected. So on PET scan, you will be finding the hypometabolism of this temporoparietal lobe. You will be finding this the hypometabolism of the temporoparietal lobe. Okay, everyone. Shall we go further? Other test you can do is the CSF examination. Is your CSF examination. In in CSF examination, what you will get? You will get low A beta 42 level. Now you will tell me, sir, you have said that there is increase of A beta 42 that you are finding in your extraneuronal amyloid plaques is there. Yes, but this A beta 240 level is an increase in neuronal part, but in CSF it is decreased. In CSF it is decreased. So there will be low A beta 42 levels. Okay. Next is your EEG. EEG is sometimes normal or non-specific or non-specific. No, Rishali, there's no pet dog because I don't have time now. So how could I care? Because they require so much caring ना बेटा. So सबको इन्वेस्टिगेशन पार्ट समझ में आ गई क्या क्या इन्वेस्टिगेशन है? जस्ट टेल मी, इज एवरीवन ओके विद द इन्वेस्टिगेशन पार्ट? धीरज, शेरनी, आर यू ओके विद द इन्वेस्टिगेशन पार्ट? शैल वी मूव फॉरवर्ड देन? Okay. Now, after completing the investigation part, we will come to the treatment. We will come to the treatment of Alzheimer disease. We will go to treatment of Alzheimer disease. Now, we all have studied. No, Shini, PET CT is not mandatory. It is up to you. It is up to you. And generally, PET CT is very good when you do this in pre-senile part of Alzheimer disease. ठीक है? Dr. Gaut. Oh, Dr. Gaut, from where you are? Are you from? Are you right now? Are you from Delhi or are somewhere outside? So, treatment for Alzheimer's disease. We all know the acetylcholine in this patient is okay. Okay, sorry. Acetyl, acetylcholine in this patient decrease. So, generally, we prescribe these patients with cholinesterase, cholinesterase inhibitors. We give patient these are cholinesterase inhibitors. So, what are the cholinesterase inhibitors we give? We give donepezil. We give donepezil at the dose of 10 mg per day, or we can give rivastigmine. We can give rivastigmine at the dose of 6 mg BD. ठीक है? Other thing we can give it, that is your NMDA antagonist. An MDA antagonist, that is your memantine. That is your memantine. And other the new drug which is coming, which is your adenosine. That is your A beta amyloid monoclonal antibody. ठीक है? So this is the treatment. But generally we prescribe cholesterol inhibitor to this patient. Now we will see some variants of Alzheimer disease. We will see some variants of Alzheimer disease. ठीक है? Now, variants. Now, first variant which will be studying is your frontal variant of Alzheimer disease. So, what do you understand by the frontal variant of Alzheimer disease? Generally, what we have studied that Alzheimer disease is a disease of parieto-temporal, and later in the course of disease, it involves the frontal part. But in frontal variant of Alzheimer disease, your so in frontal variant of Alzheimer disease, your frontal lobe is affected first. Is affected first. So generally, generally in Alzheimer's disease patient, first your memory is affected, then your prefrontal cortex will be affected. But in frontal variant of Alzheimer's disease, your you will be seeing prefrontal cortex symptom first. You will be seeing the prefrontal cortex symptom first. That is your frontal variant of Alzheimer's disease. Then is your other is your posterior posterior cortical atrophy variant of Alzheimer's disease. That is your posterior cortical atrophy variant of your Alzheimer disease. So in this patient, your parieto occipital lobe is affected. Generally, what we see in Alzheimer disease patient, occipital lobe is impaired. But in this posterior cortical atrophy patient, your parieto occipital lobe is affected first. That's why in these patient, you get visual symptom. That is your visual perception. That is visual agnosia is affected first. Is affected first. So in this patient, visual part is affected first. You can see this in this diagram. See, these are the posterior parietal and occipital lobe atrophy in the patient of posterior cortical atrophy. Okay? In a typical Alzheimer disease patient, there is first hippocampal atrophy. But in these patients, there is parietal and occipital lobe atrophy first. That is the PCA variant of Alzheimer disease. See this diagram. There is a PCA atrophy. Your posterior cortical atrophy is there. Okay? So, anyone having any doubt in Alzheimer disease, just tell me because we are now moving further. किसी को कोई डाउट है अल्जाइमर डिजीज पार्ट में जस्ट टेल मी इन कमेंट सेक्शन एनीवन टिल नाउ एनी डाउट इन अल्जाइमर डिजीज और इन मूव फर्दर so we will come to now the next disease that is your sixth disease also known as your frontotemporal dementia also known as your frontotemporal okay Dheeraj. So generally, what we know in Alzheimer disease, first your parieto-temporal involvement is there. Alzheimer disease starts with parieto-temporal involvement. And in temporal, also memory impairment is the first feature. The first feature in Alzheimer disease is your memory impairment. In frontal variant of Alzheimer disease, your frontal lobe is involved first. Generally, in Alzheimer disease, your parieto-temporal is there and frontal lobe is involved in later stages of disease after 4 to 5 years. But in frontal variant of Alzheimer's disease, your frontal lobe is involved first. That's why you will get the symptoms or prefrontal cortex symptom first. You will get the prefrontal cortex symptom first. No shielding. In later stage, it can be present. In later stage, it can be present also. Because occipital lobe, if it is bilaterally involved, it can be present. Okay? In posterior cortical atrophy, it is your parieto-occipital lobe is involved first. So you will be getting visual symptom. You will be getting visual symptom. So patient which will be coming to your posterior cortical atrophy patient first have been visited to ophthalmologist due to his visual problem. He has first has many visited to ophthalmology due to his visual problem, and now he will be visiting you. So there will be visual perception problem, visual agnosia will be there. So there will be posterior cortical atrophy. Occipital lobe involvement is there. Okay, everyone. Dheeraj, have you understood? Shall we move further? Dheeraj, have you understood? Shall we move forward, beta? My fitness mantra. I don't have any fitness mantra. Beta Rishali, go to my, I do my residency, and then I'm here to teach you all. Just in between that, if I got any time, I generally do body weight type of exercises, beta. I don't have time to go to gym. Okay, now we'll start. Now we'll starting another day, that is your pick disease. It is known as frontotemporal dementia. So disease is telling to us it is involvement of fronto and temporal. So anyone tell me what all will be the symptom? If frontal lobe is involved, then you will get prefrontal cortex symptom. And if temporal lobe is involved, you will get memory symptoms. किसी को डाउट जस्ट टेल मी एनीवन सब कुछ में आ गया पिक डिजीज एफटीडी फ्रंटल लोब के सिम्टम्स टेम्पोरल लोब के सिम्टम्स टेम्पोरल लोब मेमोरी फ्रंटल लोब प्रीफ्रंटल कॉर्टेक्स सिम्टम दैट इज कॉग्निटिव सिम्टम्स ऑफ योर प्रीफ्रंटल कॉर्टेक्स will be affected in pick disease. So it is a disease of young onset. It is a young onset disease, and it is due to loss of function of tau. It is due to loss of function of tau protein. ठीक है, ये किसकी वजह से है? लॉस ऑफ फंक्शन ऑफ tau. Other thing, it is on chromosome 17 is affected. Your chromosome 17 is affected. ठीक है, and which lobe is affected first? Your frontal lobe. So degeneration. There is degeneration of prefrontal cortex. So prefrontal cortex symptoms will be there. So can anyone tell me what all are the symptoms of prefrontal cortex? If prefrontal cortex is affected, what kind of symptoms you will get? So this patient will be socially disinhibited, loss of social embarrassment, personality changes, personality changes. Patient will be fighting and sexual abusing. So see, in frontotemporal dementia patient, his or frontal lobe is affected. ठीक है, first frontal lobe is affected. So suppose this patient is going with you in lift. In lift, suddenly he will open his all clothes. Suddenly he will open his all clothes, and you will be like, what he is doing? But actually, his prefrontal cortex is affected. So socially disinhibition is gone. Normally we don't do this kinds of activity, but he will do. We know a case. This is a 40-year-old teacher. This is a 40-year-old teacher, and he was sexually abusing his student. He was sexually abusing his student, and later on finding, it was confirmed that this patient was having frontotemporal dementia. These people will be fighting with nowhere. With nowhere, they will be fighting all the time. And in public places, they will be urinating in public places. They will be showing their private parts in public places. They will be sexually abusing others also. ठीक है? These all are the symptoms in peak disease patient. And later on, if when temporal will be not, then their memory part will be also be affected. See, this is a FTD patient. You are seeing the frontal in frontal part and the temporal part. This is the frontotemporal dementia. There is atrophy. There is atrophy of frontal lobe. Yes, yes, Puneet. This is atrophy of frontal lobe. So, if there is a patient, if there is a patient and he is having behavior symptom first. He is having behavior symptoms first, and there is a patient in which memory is affected first. So, if behavior symptoms are first, it means it is FTD. And if memory symptoms are affected first, then it means it is Alzheimer disease. It is Alzheimer disease. And later on in FTD, there will be involvement of temporal lobe and then memory affected. ठीक है everyone? Everyone got about FTD? FTD में behavior symptoms will appear first. Later on, memory symptoms will appear. Okay, everyone. Shall we move forward now? Now we will come to other type of dementia. That is your diffuse Lewy body dementia. That is your DLB. So it is the second most common form of dementia. It is the second most common form of dementia. In this, Lewy bodies, Lewy bodies are intraneuronal and cytoplasmic. They are present. ठीक है? This Lewy body can be seen in cortex as well as your basal ganglia or substantia nigra. Your substantia nigra. And this Lewy body, these inclusion bodies are made up of your alpha synuclein, alpha synuclein. ठीक है? So diffuse Lewy body dementia में these are your Lewy bodies, and these Lewy bodies have inclusion bodies of alpha synuclein. So there are three diseases. That is your Parkinson disease. That is your Parkinson disease. Then is your multiple system atrophy (MSA), and third is your DLB. These all are your alpha synucleinopathies. These are alpha synucleinopathies, and MSA and DLB, MSA and DLB are also known as your Parkinson plus syndrome. ठीक है एवरीवन? सो अल्फा सिनिक्लोपैथीज में कौन कौन सी है? पार्किंसन डिजीज, एमएसए एंड डिफ्यूज ल्यूई बॉडी डेमेंशिया. एंड एमएसए एंड डीएलबी को हम पार्किंसन प्लस सिंड्रोम्स भी बोलते हैं. एंड देयर आर सम कैरेक्टरिस्टिक फाइंडिंग्स ऑफ अल्फा सिनिक्लोपैथीज. इन these disease have REM behavior problem in sleep, REM behavior problem, okay, and there is autonomic nervous system dysfunction. There is autonomic nervous system dysfunction. There is autonomic nervous system dysfunction. ठीक है? So now we all know that diffuse Lewy body is a Parkinson plus syndrome. So there will be Parkinson features in this also. There will be Parkinson features. But in DLB, dementia predominates over your Parkinson Parkinson features. ठीक है। सो अगर एक पेशेंट है जो पार्किंसन का है एंड ही इज एन डिमेंशिया, बट डिमेंशिया इज वेरी मच प्रोनाउंस्ड एज कम्पेयर टू पार्किंसन फीचर, then this is the patient of diffuse Lewy body dementia. So can anyone tell me what all are the features in Parkinson patient? पार्किंसन पेशेंट में हमें क्या फीचर्स मिलते हैं? पार्किंसन पेशेंट में हमें क्या फीचर मिलते हैं? So, Srini, we will discuss about this REM behavior sleep problem in our sleep disorder lecture. Because if we discuss now, then class will be very much long. हाँ, cogwheel rigidity, bradykinesia, bradykinesia, ठीक है, rigidity, stoop posture, and tremors. ठीक है, these all features we get in Parkinson. But in diffuse lower body dementia, there will be dementia predominates. In this, dementia predominates. And this dementia is like, it is a fluctuating. It is a fluctuating type of dementia. It is a fluctuating type of dementia, and there is memory loss. And the most characteristic feature is the visual hallucination. Visual hallucinations. ठीक है? So there is a patient on whom there is Parkinson feature as well, because Parkinson patient को dementia, maximum Parkinson patients suffer from subcortical dementia. Okay, but if there is a patient in which dementia is predominating over Parkinson feature, then it is your diffuse Lewy body dementia, and this dementia is fluctuating type, and there are presence of visual hallucination, which are characteristics of diffuse Lewy body dementia. Dif- Diffuse Lewy body dementia. अब होगा क्या? If patient is coming to you of hallucination, suppose if hallucination patient is coming to you, generally what we prescribe hallucination patient, we give them antipsychotic, we give them antipsychotic, and we all know that antipsychotic decrease dopamine, antipsychotic decrease dopamine. So if to this patient, if you give antipsychotics, and in this patient there is a decrease in dopamine, because we all know Parkinson feature is through decreasing dopamine, so his visual hallucination will increase, his visual hallucination will increase. That's why this visual hallucination doesn't respond to antipsychotics, doesn't respond to antipsychotics. सबको समझ में आ गया कि why in diffuse lower body dementia patient, because they are having visual hallucination, but they doesn't respond to antipsychotics, because generally on in hallucination we prescribe antipsychotic, but when we give antipsychotic there is decrease in dopamine, and diffuse Lewy body is a Parkinson plus syndrome. In Parkinson plus, they already decrease in dopamine is there, so if we prescribe them antipsychotic there will be further decrease in dopamine. That's why they doesn't respond to antipsychotics, they doesn't respond to antipsychotics. And as it is in a Parkinson plus syndrome, as it is a Parkinson plus syndrome, generally Parkinson respond very good to levodopa. But as this is a Parkinson plus syndrome, so there is a poor response to levodopa. There is a poor response to levodopa. ठीक है, everyone? Shall we move further? सबको diffuse Lewy body dementia समझ में आया? It is a type of a Parkinson plus syndrome, and it is a type of alpha-synucleinopathies. Alpha-synucleinopathies की two characteristic features क्या है? One is REM behavior problem, and other is the autonomic nervous system dysfunction. Okay, sir. Other, in diffuse lower body dementia, if a patient of Parkinson is coming to you and he is not responding to levodopa, and in that patient dementia is predominating, then you will suspect diffuse lower body dementia, and you will ask the history of visual hallucination. You will ask the history of visual hallucination. So if visual hallucination is there, fluctuating dementia is there, patient is poor responding to levodopa, and tremors are, as this is a Parkinson plus syndrome, so tremors will be less predominant here. Tremors will be less predominant. Then you suspect diagnosis of diffuse Lewy body dementia. Okay, everyone, shall we go further? Just tell me in comment section. Shall we go further? Everyone, just tell me in comment section. Shall we go further? ठीक है. Next is our next is our prion disease. It is a prion disease. So yes, Vishal. Next is your prion disease. So prion disease, the most important thing, it is a it is a onset, young onset and rapidly progressive dementia. Rapidly progressive dementia. ठीक है. And prion these are they are slow virus. These are slow viruses. So it is due to it is due to TRPSC proteins, which are beta pleated sheets, and it is an infectious protein. ठीक है. Yeah, these patients die within 1 or 3 years. These patients die within 1 or 3 years, and generally onset of age is 30, 20 to 30 years is onset of age. Like Alzheimer disease patient, if suppose if I'm an Alzheimer disease patient and now symptoms develop to me, then I can live around 8 to 10 years. But in prion disease, there is 100% mortality is there. Generally, there is a 90% mortality is there, and patient dies within 1 or 3 years. Patient die within 1 or 3 years. So patient dies within 1 or 3 years. Everyone till now, and any doubt? Now, in this first is your CJD. That is your Creutzfeldt Jacob disease. Okay. ठीक है. Now, for your level, you have to remember only 2 or 3 things regarding this disease. That is, this disease present to you with dementia plus motor myoclonus changes motor myoclonus changes, and on EEG you will get high voltage complexes. High voltage complexes. ठीक है. Only this thing you have to remember. So if a patient is coming to you with dementia with motor myoclonus changes, then it is your CJD. So I will give you a short table. If a 30-year-old patient with dementia with myoclonus, it is CJD. And if a 50-year patient, it is dementia, and with this is chorea, then it is Huntington disease. Okay, everyone? ठीक है. Shall we go further now? Now we will study, that is your other is your NPH. Other is your NPH. H, that is your normal. So what do you mean by myoclonus? Okay, here myoclonus are sudden jerks. Myoclonus are the sudden jerks of muscle, like this. Sudden jerk. Myoclonus are sudden jerks. Okay, Dheeraj. Myoclonus are the sudden jerk. Generally, clonic movement. One is clonus. Clonus is rhythmic and happens in all parts of body generally. And clonus always happen with tonic movement. First is your tonic, then comes your clonus. That is your tonic cloning movement. Myoclonus is generally sudden jerks of any muscular movement. Yeah. Next is your NPH. That is your normal pressure hydrocephalus. ठीक है? It is a non-communicating type of hydrocephalus. ठीक है? It is a sorry. It is a communicating type of hydrocephalus or your non-obstructive non-obstructive hydrocephalus. Generally, there is a problem in CSF absorption. There is problem in CSF absorption. There is defect in CSF absorption. ठीक है? It is a subcortical dementia. It is a type of a subcortical dementia. It is a type of a subcortical dementia. In further slide, I will tell you the difference between a cortical dementia and subcortical dementia. Till now, you just remember that it is a subcortical dementia. And I have told you this MRI finding. See this. This is the NPH patient MRI. This is the NPH patient MRI. Where there dilatation of ventricle is there, gross dilatation there, but Gara and Salki are normal here. Gara and Salki are normal here. So, so we have to remember the triad in this patient. The triad is like this. Can you tell me the triad of NPH? Anyone? Triad of NPH patient. It is your urinary incontinence. First is your gait instability. Then is your urinary incontinence. And third is your dementia. And third is your dementia. ठीक है? In gait, this is your gait apraxia. This is your gait apraxia. Okay, everyone? Yeah, NPH is reversible. It comes under reversible dementia. Okay, everyone, shall we move further? ठीक है, okay. Now we will move on to the difference between the cortical and subcortical dementia. So can anyone tell me how do you differentiate between cortical and subcortical dementia? Anyone? How do we differentiate between a cortical and subcortical dementia? I will draw a table. Cortical dementia, and that other is your subcortical dementia. Then cortical dementia example is your Alzheimer disease. Is your Alzheimer disease. And subcortical is like your diffuse Lewy body dementia. Other is your normal pressure hydrocephalus. See, I have told you in my memory class that when it's come to memory, and there are two types of memory. In implicit memory, when there is, see, if we go to this slide, if we go to this slide, see, I have told you in my last class, when we come to long-term memory, and long-term memory, the implicit memory, that is a procedural skill memory, in which sensory motor both are involved, it is controlled by your basal ganglia and cerebellum. So, so your subcortex also help in your memory. So, your subcortex also help in your memory. And other thing I have told you that in my last class, that when it comes to prefrontal cortex, because prefrontal cortex help in cognitive function, and prefrontal cortex has connection with subcortex, has connection with subcortex, that is from frontostriatal fiber. So if your basal ganglia, your subcortical is affected, then you will get dementia, because one thing, it is controlling your implicit memory, that is your procedural motor, that is your procedural motor. Other thing, it is has connection with prefrontal cortex also. So these fibers will also affected. So dementia will be there in subcortical, but it will be less as compared to cortical. But dementia will be there in subcortical patient. No, Parkinson is subcortical. Okay. Now see, first, dementia here will be more severe. Dementia here will be more severe. It will be less severe. Okay. Here, memory loss is severe, because in cortical temporal lobe will be gone, so severe memory loss. Here, memory loss will be there. One, there is implicit memory loss will be there little bit, and as it is connection with prefrontal cortex also, so there will be memory loss, but mild memory loss, mild to moderate memory loss. Then third, as it is a subcortical, so generally basal ganglia will be affected, so you will be getting a Parkinson like feature. Parkinson like feature you will be getting, but these will be absent in the cortical dementia. Other thing, yes, yeah, Puneet, you can say like this also. Other thing, your apraxia and agnosia will be there, but it will be absent in your subcortical. It will be absent in subcortical. Other thing, generally these patients give quick and wrong answer. They give quick and wrong answer. But subcortical dementia patient, they give slow and right answer. They give slow and right answer. ठीक है? Done everybody? तो सबको समझ में आ गया? In cortical dementia compared to subcortical dementia, in cortical dementia there will be severe impairment of memory. Because why? Because in cortical dementia, your temporal lobe is gone. Your temporal lobe is gone. And temporal lobe, who is sitting temporal lobe? Is your hippocampus. And hippocampus, there's short-term memory. There is episodic memory also. And for converting long-term memory, you need a short-term memory. So as your temporal lobe is gone, that's why there will be a severe memory loss in cortical dementia. But when you compare it to subcortical, the memory loss will be mild to moderate. Then Parkinson feature will be more in subcortical dementia, but it will be less in cortical dementia patient. Then comes your apraxia agnosia. It will be present in Alzheimer disease patient, but it will be absent in subcortical. And your cortical dementia patient, when you will ask him, he, where do you live? And suppose he is living in Delhi, he will say you, I am living in West Bengal. I am living in West Bengal. He will fast answer. But when you ask this question to a patient of subcortical dementia, he will first take his time. He will slowly reply. After some time, that I live in Delhi. So subcortical will give you slow and right answer. Cortical will give quick and wrong answer. Take care, everyone. Shall we now move forward? So just tell me. Here we are making a table. Just see this table. I am making a table for you. Okay. So just I am making a table for you, and you all have to give answer to me. So this is a patient in which medial temporal lobe, medial temporal lobe plus your frontal lobe and plus your parietal lobe is gone. What is the disease? Your medial temporal lobe plus your frontal parietal lobe is gone. What is the disease? Just tell me. This is a patient in which medial temporal lobe is gone, frontal and parietal lobe is gone. Tell me the disease. Tell me the disease. Okay, Alzheimer. Okay. But here I'm saying frontal lobe. Okay. It is a Alzheimer disease. Okay, Arvind, good. See our other patient. This is a patient start. This is a starting lobe. Okay. This is another patient in which first is frontal lobe and now is medial temporal lobe. Tell me the disease. Tell me the disease. First in lobe is your frontal lobe. Now is your medial temporal lobe. What is the disease? No, it is not FTD. Okay, I will give you a clue. It is medial temporal lobe plus parietal lobe. Now tell me. Now tell me. Frontal lobe, now medial temporal lobe plus parietal lobe also. Tell me now. Tell me now which lobe is involved. Tell me now which lobe is involved. Tell me now which lobe is involved. It is your frontal variant of Alzheimer disease. It is your frontal variant of Alzheimer disease. Another is, see this. This is lateral temporal lobe. This is lateral temporal lobe plus frontal lobe plus frontal lobe. Now this is your FTD. In FTD, the lateral part of temporal lobe is affected. In FTD, the lateral part of temporal lobe is affected. So this is semantic memory. This is semantic memory. And if medial part is affected, then it is your episodic memory. Then is your episodic memory. Now tell me another thing. If there is a patient, if there is a patient in which occipital lobe is affected, your occipital lobe is affected. Tell me the condition. Your occipital lobe is affected. And then your occipital and parietal lobe are affected. Tell me the condition. Your occipital and parietal lobe are affected. Tell me the condition. Your occipital and parietal lobe are affected. It is posterior cortical atrophy, a variant of Alzheimer disease. A variant of Alzheimer disease. Okay, everyone. Now tell me another thing. There is a patient in which only occipital lobe is affected. Only occipital lobe is affected. Tell me the answer. This patient, only occipital lobe is affected. This is your diffuse Lewy body dementia. This is your diffuse Lewy body dementia. This is your diffuse Lewy body dementia because there are visual hallucination in diffuse Lewy body dementia. Na? So you have to look for the lobe from where it has started, from where it has started, and till which lobe it has progressed. Then you will be able to make the diagnosis. You first have to look the lobe. So just with me, if medial temporal lobe is affected, if medial temporal lobe is affected, it is Alzheimer disease. If lateral temporal lobe is affected, it is frontal temporal FTD. Medial temporal plus frontal parietal Alzheimer disease. But first frontal lobe is affected. But first frontal lobe is affected, and then medial temporal is affected. It is frontal variant. If lateral temporal lobe is affected, then frontal lobe, it is FTD because in FTD lateral temporal is gone. In Alzheimer, medial temporal is gone. Then comes occipitoparietal lobe is affected. Then it is your TCA, posterior cortical atrophy variant of Alzheimer's disease. And if only occipital lobe is affected, then it is your DLBD, diffuse Lewy body dementia. Now, another thing, if there is a patient of dementia, if there is a patient of dementia, plus he is having some systematic, he is having some systemic features or manifestations like his CVS, RS are also involved, then what disease you will think? If there is a patient of dementia plus systemic manifestations are there, plus systemic features are there, means CVS, RS are also involved, then which disease you will think? Just tell me in comment section. No, no, no. This patient systemic features are there. In Alzheimer, there are only features of CNS. Later on, due to bedridden patient get other symptoms. If there's a patient of dementia plus systemic features, then you will think of disease like rheumatoid arthritis. You will think of SLE. You will think of vascular dementia. You will think of hypothyroidism. Because in last class, we have studied that hypothyroidism is the cause of reversible dementia. Okay, everyone? Shall we go further? Okay. Now we will study that is your vascular dementia. That is your vascular dementia. That is your vascular dementia. ठीक है? It is of two types. One is your large vessel and other is your small vessel. ठीक है? Large vessel are most common are due to stroke. Are most commonly due to stroke, and small vessel are due to white matter changes. Are due to white matter changes, especially in your subcortical area. Especially in your subcortical area. ठीक है? So vascular dementia is of two types. One is your large vessel, other is your small vessel. Large vessel are mostly due to stroke, and small vessel are due to white matter changes. Small vessel is due to white matter changes. That is your subcortical area. Okay. Now, first we'll study about the large vessel stroke. Large vessel disease. ठीक है? It is generally due to a stroke. ठीक है? So what all are the characteristic features of large vessel stroke? It is dementia. ठीक है? So there will be features of CVA. And CVA के क्या features हो सकते हैं? There will be contralateral hemiplegia or quadriplegia. Weakness will be there. UMN signs will be there. Tone will be increased. Reflex will be increased. Babinski sign can be there. Other thing is other thing is onset of Yashri. Depending on the area involved, you can also select onset of dementia should be within 3 months of stroke. ठीक है? Within 3 months of stroke. And other thing is that these dementia in large vessel stroke, it is a fluctuating type. It is a fluctuating type. So now, can anyone tell me? I have told you that there is one disease also in which fluctuating dementia is there. There is one disease I have told you previously that also has a fluctuating dementia. Can you tell me that disease? Large vessel disease also has fluctuating dementia. I have told you one disease also which has fluctuating dementia. Can anyone tell me in comment section? Yeah, Shri, LBD, diffuse Lewy body dementia. That also has fluctuating dementia. Large vessel also has fluctuating dementia. Fluctuating plus it has a stepwise progression. Stepwise progression. Stepwise progression of dementia. See this diagram you see. This is the cognitive impairment and this is the time. See how Alzheimer disease patient graph is there. And when there is a stroke patient, see this, there is a stepwise approach. There is a stepwise progression is there. Okay, everyone? In stroke patient, the loss of cognitive function, has a stepwise approach, has a stepwise progression and a fluctuating. But normally in Alzheimer patient, it is not stepwise. It is fast. It is chronic, but there is no stepwise progression is there. But in a large vessel stroke, it is a stepwise type of pattern. ठीक है एवरीवन? सबको लार्ज वेसल समझ में आ गया? So large vessel is generally due to stroke. Dementia will be there. CV feature will be there. Onset of dementia should be within 3 months of stroke. And dementia will be a fluctuating type and it will be a stepwise type of dementia. After completing large vessel, we will move on to small vessel. In small vessel, I have told you that it affects the white matter. It affects the white matter. It affects the white matter. Now see, small small vessel dementia. ठीक है? So it is what is it? It is white matter. It is basically a white matter disease. It is basically a white matter disease. So white matter changes in subcortical area. In subcortical area, and there will be hyper intensity of white matter. There will be hyper intensity of white matter. Shri Singh lacunar stroke. Yeah, sometimes it can be lacunar stroke also, but generally it is a white matter disease. Generally it is a white matter disease. See this MRI image. Here we are seeing the ventricles. Okay. In this in brain, your gray matter is outside. Your gray matter is outside, and inside is your white matter. Inside is your white matter. And here we are seeing the hyperintensities in white matter, the white lesions in white matter. We are seeing hyperintensity in white matter. Okay, everyone. सबको समझ आ गया? Small vessel disease में you will get hyperintensities in white matter. Now, how this disease will come to us? What all series like T1 or T2? So just tell me how will you distinguish between a T1 image on MRI versus T2 image? If this is your MRI, in MRI there are two, T1 and T2. Okay. Then comes your gray matter. Then comes your white matter. Then comes your CSF. So just tell me the difference. Just tell me the difference. Anyone in comment section? Anyone? Anyone in the comment section? Yeah. CSF will be anyone? Yeah. CSF will be dark in T1, but CSF will be dark in T2. Okay. Then your gray matter. Your gray matter will be gray on T1 and it will be white on T1. But your gray matter on T2 will be white. But your white matter on T2 will be gray. Your white matter on T2 will be gray. Okay, everyone? Okay? Yeah. So now due to due to involvement of white matter, due to involvement of due to involvement of due to involvement of white matter. So what all disease can be present? So due to involvement of white matter, there can be pseudobulbar palsy. There can be pseudobulbar palsy as white matter. So your corticobulbar tract will be there. Your corticobulbar tract will be there. Your corticobulbar tracts are made of white matter, and if corticobulbar tracts are damaged, then there will be pseudobulbar palsy. And what is the difference between pseudobulbar palsy and bulbar palsy? I will tell you in my next lecture of aphasia. Okay, everyone? Yeah, human findings can be there, Shri. Good. And there can be gait abnormalities or urinary abnormalities. ठीक है? Yeah. Why gait abnormalities, urinary abnormalities? Because your frontal lobe, because your gait abnormality urinary continence is associated with frontal lobe, and your frontal lobe has having white matter connections, and when this white matter will be damaged, you will be getting the gait abnormalities and urinary abnormalities. Other is your now see this question. Now see this question. This is a now before we will do a there is another disease that is known as your cardacil, which comes under this small vessel also. This comes under your small vessel. That is your cardacil. So what cardacil stands for? Cardacil stands for your cerebral autosomal dominant arteriopathy with stroke and leukoencephalopathy. ठीक है? So it has a strong family history, strong family history, dementia plus migraine and plus aura plus stroke can be there. ठीक है? Now see this question. This is a 42-year-old female patient presented to you with the complaints of headache for 6 years. It presented to you with the it presented to you with the complaints of headache for 6 years with the frequency of 2 episodes per year. ठीक है sir. It presented to us with headaches. She has a sustained progressive mental deterioration since 8 years ago. She had a sustained progressive mental deterioration since 8 years ago. Okay. The patient also suffered from intermittent occasional numbness of left arm and left leg. It means there is weakness, a stroke is there. Patient suffered from behavioral changes. There is loss of cognitive function. And her family history revealed that her father died at the same age. It means family history is positive. And uncle died also from cerebral stroke also. So there is stroke, there is headache, strong family history is positive. And when we have done the MRI, what we have found? There is hyperintensity of white matter. There is hyperintensity of white matter, and that also in your subcortex. That also in your subcortex. So what will be the diagnosis? White matter hyperintensity. Stroke is there, maybe lacunar stroke. Stroke is there, maybe lacunar stroke. Headache is history is there, family history is positive. It is cardacil. It is cardacil. Okay, Shri? No, not large vessel. You are getting white matter hyperintensity. You are getting white matter hyperintensity. Family history is there. Headache is there. Stroke is there. It is small vessel stroke because you are getting white matter hyperintensities on MRI. On on stroke is generally localized to vessel. Okay. Yeah. Yeah, Sharmami. It is a vascular dementia with small vessel. And as it is having family history positive, so it is cardacil. Okay, everyone? Yeah. Okay, everyone got this? Now see. Now we have completed with the dementia. Just see this diagram. This is the lateral view, and this is the medial view of lobe. Okay, done. So first come to the aphasic component. First come to the aphasic component. So what Harrison is saying? So Shani, yeah, you are right. We can confuse with this small this when this is a small vessel white matter disease, we can confuse this with multiple sclerosis also many times. Okay, you are right. So first we have to look into symptoms, family history, and there are some other findings in MRI also for this. But if I will tell that, then this lecture will be a long. Okay, Srini, we will discuss this in our multiple sclerosis lecture. That how should we differentiate between multiple sclerosis and small vessel white matter disease on MRI. Okay, Srini. So see, so see this middle view. In this, it is amnesia. So amnesia is due to memory loss. Amnesia is due to amnesia is due to memory loss. ठीक है? So see, Alzheimer disease has greater chances than frontotemporal lobe dementia because in frontotemporal, there first frontal lobe is damaged, then symptoms of memory loss occur. But in Alzheimer, first memory loss is there. So amnesia will be more prominent in Alzheimer disease, amnesia. Then comes your visuospatial disorientation. In visuospatial disorientation, we have seen that there is a variant of Alzheimer disease that is your posterior cortical atrophy. And in posterior cortical atrophy, there is parieto-occipital involvement is there. So visual spatial involvement will be first in PCA, then Alzheimer disease, then comes your diffuse Lewy body, and last is your frontal temporal lobe dementia. Okay. Then is your behavior. We all know behavior is all about prefrontal cortex, and prefrontal cortex is controlled by your frontal lobe. And in FTLD, frontotemporal lobe dementia, first damage is your frontal lobe. That's why you will get behavioral symptoms first in your frontal temporal lobe dementia as compared to your Alzheimer disease. Okay, see this table. This is a table of this is a table given in Harrison. See, we'll start with Alzheimer disease. Okay, first symptom is memory loss because hippocampus is affected. Mainly episodic memory loss is there. Later on, you can get irritability, anxiety, depression. Okay. Next comes your frontal temporal lobe dementia. It first affects your frontal lobe. So there will be apathy, poor judgment, speech language issue, hyperorality. Patient will be fighting. He will be unbuttoning and buttoning in front of public. Okay. He will be sexual abusing the patient. So frontal lobe features will come first. So there will be frontal executive symptoms which are present first. Next is your diffuse Lewy body dementia. In this, first is your visual hallucination. And we all know that DLB is a part of alpha-synucleinopathies. So it also have REM behavior and Parkinson feature will be also there. Okay? See, visual hallucination, depression. Then is your CJD, prion disease. In this, dementia will be there, movement disorder will be there, like myoclonus will be there, and depression, psychosis. Then comes your, yeah, yeah, Shri, ANS also. In alpha-synucleinopathy, autonomic nervous system is also involved. Then comes your vascular. See, it is sudden, variable, apathy, and focal weakness. Focal weakness means focal neurological deficit. If it is a large vessel disease, there will be hemiplegia. So it is a focal neurological deficit. It will be frontal, cognitive slowing is there, and it generally spares memory initially, but later on it also involves memory. ठीक है? And usually motor slowing, spasticity. Why spasticity? Because rigidity happens in Parkinson. Rigidity is an extrapyramidal feature, and spasticity happens in your stroke patient, that is UMN feature. So there is spasticity in vascular dementia. Okay, everyone, clear till now? Shall we move forward? Shall we move forward, beta? ठीक है। नाउ बिफोर वी वाइंड अप दिस लेक्चर, वी विल फर्स्ट सी दिस dementia is an umbrella term. It is an umbrella term. It is a collection of brain disease, their symptoms, which include memory loss, impaired judgment, personality change, and inability to perform daily activities. So, dementia is an umbrella term in which comes your Alzheimer, which there is vascular also, there is frontotemporal dementia, there is Lewy body dementia, and there is other dementia also. Okay? Now we will, before winding up this lecture, we will see the diagnostic approach. We will see the diagnostic approach, how to approach a patient of dementia. So first, if a patient is coming to you in OPD basis, first you will check for cognitive impairment. You will check for cognitive impairment is present or not. Then you will compare that cognitive impairment with the deterioration from a previously higher level. It means, suppose if I am coming to you, if suppose I am coming to you and I am having cognitive impairment earlier also, and now also I'm having cognitive impairment, and these both cognitive impairment are same, then this is your mental retardation. But my cognitive impairment is changed, or earlier I was normal, but now I am having cognitive impairment, or earlier I am having cognitive impairment that is less, but now I am having cognitive impairment which is more, then I will think of other causes. So deterioration from a previously higher level present or not. If it is not present, then it is a mental retardation. Next, if this is not present, then you will check the consciousness and alertness. Then you will check the consciousness and alertness. If consciousness and alertness, if if consciousness and alertness is absent, then it is your delirium. So is patient conscious now alert? No, patient is not. So I will repeat it. First, we will check the cognitive impairment, then we will come to deterioration from previously higher level. If it is absent, then it is your mental retardation. Then you will check for consciousness. If consciousness is altered, then it is your delirium. Then it is your delirium. If consciousness is preserved, then you will come to other. Then you check for other cognitive functions. Then you will check for other cognitive function. If multiple cognitive functions are involved, if multiple cognitive functions are involved, then you will go further. But if multiple cognitive functions are not involved, if suppose only language issues there is because in cognitive function there are many cognitive functions. There is memory, there is language. Suppose only one cognitive function, that is language, is involved, but multiple are not involved, then you will think of aphasia. And if only memory is involved, then you will think of amnestic. Then you will think of amnesia, that is memory loss. But if multiple cognitive functions are involved, then you will move further, and then you will check if this cognitive function are affecting daily activities or not. If they are not affecting daily activities, then it is MCI, and if they are affecting daily activities, then it is dementia. Then it is dementia. Now I'm repeating again. A patient is coming to you. Okay? Suppose I am a patient coming to you, and I will take this in Hindi. I am coming to you a patient of cognitive impairment. You will compare my cognitive impairment with my earlier. If my cognitive impairment compared to my earlier life, first, if it is improved, if it is increased, then you will consider it is a part of dementia. Or if earlier I was normal, but now I'm having cognitive impairment, then you will consider it part of dementia. But if I was having cognitive impairment earlier also, और मेरे को अभी भी cognitive impairment है, then it is a mental retardation. Then you will check my consciousness level, if I am a conscious or not. अगर मैं मेरी consciousness preserved नहीं है, then it is delirium. Okay. Now we'll check for other cognitive function also. अगर एक ही cognitive function involved है, then if language, then aphasia. If it is only memory, then it is amnesia. But you will check for other cognitive function. अगर other cognitive function involved है, then you will think more in terms of dementia. Then you will check कि daily activities affected है तो नहीं है. अगर daily activity affected है, then it is dementia. If not, then it is MCI. Everybody has got this diagnostic approach. अगर किसी को समझ नहीं है, just tell me in comment section. If anyone is having any doubt in this diagnostic approach, just tell me in comment section. See, I will repeat again. एक पेशेंट है हमारे पास, ठीक है, इसको कॉग्निटिव इंपेयरमेंट है. मैं इसकी कॉग्निटिव इंपेयरमेंट करूंगा इसकी पहले के लाइफ से. अगर इसकी कॉग्निटिव इंपेयरमेंट उतनी ही है जितनी पहले थी, तब तो ये मेंटल रिटार्डेशन पेशेंट है. बट अगर इसकी ड्यूरेशन बढ़ी है, या इसको कॉग्निटिव इंपेयरमेंट अभी प्रेजेंट हुई है, पहले नहीं थी, देन आई विल कंसिडर हाँ ये डिमेंशिया हो सकता है। ठीक है, फिर मैं चेक करूंगा इसका कॉन्शियसनेस लेवल। अगर ये ऑल्टर्ड कॉन्शियसनेस में है, देन आई विल थिंक इन टर्म्स ऑफ डिलीरियम। ठीक है, अगर डिलीरियम नहीं है, देन वी विल गो फर्दर। व्हेन वी विल गो फर्दर, अगर एक ही कॉग्निटिव फंक्शन इन्वॉल्व है, वी विल थिंक इन टर्म्स ऑफ अफेजिया एंड एमनेसिया, कि आप भाई सिर्फ लैंग्वेज है तो अफेजिया एंड मेमोरी तो एमनेसिया। We will check for other cognitive function. अगर other cognitive function में involved है, then it will assure that हाँ we are moving in terms of dementia only. And then we will check if these are affecting his daily activities or not. If daily activities are affected, then it is dementia. If not, then it is MCI. Okay, everyone. सबको क्लियर है? Just tell me in comment section. Are you okay with this dementia approach? Anyone having any doubt? Just tell me. Is everyone okay with this dementia approach? Because in last lecture I have told you that before you label a patient a dementia, you have to first rule out delirium and depression. You have to first rule out the delirium and dementia and depression. Now, everyone, just tell me a condition in which pseudo depression is there. Tell me a condition. Oh, sorry. Tell me a condition in which pseudo dementia is there. I have told you in my next lecture. There is a condition which we call as pseudo dementia. Tell me the condition which we call as pseudo dementia. Depression. Very good, Dheeraj. It is your depression. So you have to rule out depression. And in depression, many times you can get a false MMSC test, false MMSC positive test in depression. Because depression patient, because there is your MMSC score, and you will ask him question, but as this patient depression, he will not give you answer, and score will be positive. So there can be a false positive MMSC test in the depression patient. There can be false positive test in this depression patient. Okay, everyone. Everyone got this? Now, before winding up this lecture of dementia, what three things we have to look in a dementia patient? One out of six cognitive features. Okay, sir. Done. Rule out delirium. Rule out dementia. Sorry. Rule out depression. And then label that patient as dementia. And then label this patient as dementia. And any patient coming to you with the history of dementia, you have to first also rule out what condition. You have to also rule out the reversible causes of. You have to rule out the reversible causes of dementia. So can हाँ, because many all these conditions of dementia generally are non-curable, but only 10 to 20% of dementia, which is a reversible dementia, it is only reversible. So it is your duty whenever a patient is coming to dementia, first you have to always rule out the reversible causes of dementia. Yeah, Shri. So what is the mnemonic? It is your dementia, where D stands for drugs, E for your endocrine, that is your hypothyroidism. ठीक है? M stands for metabolic, that is your vitamin B12. I for eye and ear. N stands for NPH. Yeah, Shri. Drugs like benzodiazepine, your TCA. T stands for trauma, I stands for infection, and A stands for anemia. ठीक है everyone? Just किसी को doubt? We are completing this session. Thank you. Anyone having any doubt? Just tell me. Anyone having any doubt? Next lecture will be on aphasia. Next lecture will be on aphasia. Okay, everyone? Most probably tomorrow, day after tomorrow at 7 p.m. Next lecture will be on aphasia, 7 p.m. or 8 p.m. Okay? Okay. Thank you. Good night.